Okay. So, good evening everyone. I think I'm connected and we are going to discuss. I guess everything is fine. Just let me check, recheck. Yeah. So, anyone who is connected before I started streaming has to go out and check in again. Now you log in again. Otherwise, the screen will be blank. So, go back and log in again. Okay. So, I'll just go through the questions. The INICET question paper was little erratic. Not the core questions were there. Somewhat aberrated questions were there. Lots of overlap were there. Superficial paper, not very deep. And I'm not very happy to see the paper. But anyway, this is what we had this year. This is a very typical question, breast cancer staging, one of the favorite topic for your exam. So, this is one thing you cannot afford to miss. Breast cancer staging, you have to read very thoroughly, which is not 4B. As you know, 4A is muscle involvement. In muscle, they do ask pectoralis major and minor. As you know, pectoralis is not part of muscle involvement. Only serratus anterior or ribs or intercostal muscles are. Likewise, 4B skin involvement. Skin involvement does not include inflammatory breast cancer, which is 4D. So, ulceration, satellite nodule and pudy orange. These three are 4B, while inflammatory breast cancer is 4D. There is nothing to discuss here. I am sure we all have discussed lots of, staging in which breast is very important. So, ये बड़ा common सा question है. Let's leave this. A, B, C are part of 4B, not D. Now, a patient presented with breast lump. On imaging, along with histopathology, there is a confirmed diagnosis of breast cancer. She has a family history. Whenever family history is positive, that too young age, you have to go for genetic screening. And we all know BRCA1 and BRCA2 gene are the two main genes which are very strongly related with breast cancer. It should be screened almost always if family history is there, or young age cancer, or in family male breast cancer history is there. BRCA1 on chromosome 17, BRCA2 on chromosome 13, and BRCA1 has a more association 70 to 90% to 60%, but both are strongly associated. TP53, which is Lee-Fraumeni syndrome, can also cause CDH1, which mutates E-cadherin. E-cadherin is for lobular cancer, and STK11 is Peutz-Jeghers. All three can cause breast cancer, but screening is only done for BRCA1. 25-year-old presents with pain starting from lichen moving towards right iliac fossa, fever, nausea, vomiting, rebound tenderness. Well, you may have more features, may have less features. This is not an exact replication of the question asked, but I think this was the question, and this is based on Alvarado score. Alvarado score is basically Mantrel, MANTRELS. MAN symptom, TRE sign, LS investigation. Migratory pain 1. So, there is a pain which is migrating, so I'll give 1 number. Anorexia probably was there in the question, was not there, I'm not sure. Let's leave it. If it was there, you can add 1. Nausea, it is there 1. Tenderness 2. Rebound tenderness 1. So, this is not there, this is not there, this and this. Elevated temperature. Leukocytosis 2. Shift to left, not there. So, in general, according to this, the answer will be migratory pain 1, fever 1, nausea 1, 3, rebound tenderness 1, and nausea is 1. So, according to this, the answer will be 6, but not necessary, maybe 7, depends what all points were there. So, this is the Alvarado score. I guess कि ये आपका सही हुआ होगा. This is a very commonly and very favorite topic for MBBS exam, Viva, theory, MCQ, everywhere. The next question was a tricky question. A 65-year patient has a cancer colon. Size is irrelevant in TNM. Size doesn't matter in GIT. Depth is T. Adenocarcinoma only involving the mucosa. Involving mucosa is TIS. which is stage 0. The colon cancer staging I discussed in detail in regular, discussion, regular batch. TIS carcinoma in situ, T1 is divided into A and B, which is muscularis mucosae and submucosa. T2 is muscle, T3 is beyond the muscle but up to serosa, should not be serosa, and T4 is outside serosa, which is further divided into A and B. A is visceral peritoneum involved and B is surrounding structure invaded. N1 less than 3 node, N2 more than 4 node. Less than 3, N1A single node, N1B 2 or 3 node, N1C perinode fat involvement, N2 4 to 6 N2A and more than 7 N2B. So the staging is, this is 0, these two are 1, these two are 2, this is 3 and metastasis 4. I'll show you here. All you can remember in detail, but I don't think they'll ask in detail. Only remember carcinoma in situ T0, 1 and 2 is stage 1, 3 and 4 is stage 2. If node is there, stage 3, metastasis 4. Very simple staging, right? So here the question was mucosa involvement, so it is stage 0. Not a contraindication of breast conservation surgery, that also is a very favorite topic. Absolute contraindication are only 2. One is N2, second is multicentric. Multicentric means multiple outside the quadrant. This is what they do ask. What is multifocal and multicentric? Multifocal, multiple in one quadrant, that's not a contraindication because you can do quadrantectomy. But multicentric outside the quadrant is a contraindication. That's a N1 is not a contraindication, N2 is. These two are absolute contraindication. Other relative contraindication are collagen vascular disease like scleroderma, past history of radiation, size less than 4 centimeter is the indication, more than 4 is contraindication relative, because even more than 4 we see the breast tissue ratio. So more than 4 is relative. Family history positive, BRCA gene, all double cancer, all these are relative contraindication. Earlier centrally located tumor below nipple area complex was also contraindication. Now it's not a contraindication anymore. So multiple cancer in one quadrant which is multifocal is not a contraindication. You can do quadrantectomy here. So this comes under, it's not a, you can do breast conservation here. Which of the following is wrongly matched classification? Boston is for colon preparation, 0 to 3 grades. LA is not for achalasia, this is for GERD. Mannheim for chronic pancreatitis and Miami for parathyroid. Parathyroid adenoma and hyperplasia differentiation. If it's adenoma and hyperplasia confusion, you remove the adenoma during surgery, wait, get the PTH done after 10 minutes. If parathyroid hormone is still high, then this is hyperplasia. It's not high, it's adenoma. It's gone down less than 40%. This is the workbook photo of that particular page of GERD, DAMS workbook, where I have written some names of endosome classification of GERD. Muse, the full form is metaplasia, ulcer, stricture, erosion. Savary-Miller, LA. LA is for GERD, not for achalasia. We do have long segment also in GERD Barrett's, which is more than 3 centimeters. That's, and this is the Boston. The colon is totally unprepared, full of fecal matter, some fecal matter and mucosa, quite clean, but still fecal matter, they are absolutely clean. 0, 1, 2 and 3 grades are there for Boston colon preparation. So the wrong is LA for achalasia. Imminent gangrene is seen in ABPI, ankle brachial pressure index. ABPI is a very first test we order when we have peripheral vascular disease like Burgers, etc. You measure the systolic blood pressure in the upper limb and systolic blood pressure in the lower limb. Ankle upon brachial pressure index. Ankle pressure is more, so it is 1 or more than 1 that we consider normal. The problem is the blood pressure may differ during inspiration and expiration. So, imagine the ankle pressure taken during peak expiration, it may be low, brachial pressure taken at peak inspiration can be high. So, some discrepancy can be there. So, we have given a margin of 0.9. So, above 0.9 we do not consider abnormal, below, although it should be more than 1, but up to 0.9 is okay. Less than 0.9 is abnormal. Less than 0.7 you get claudication. Less than 0.5 rest pain, which is the MCQ. This was a question I gave in grand test also last year. Less than 0.5 and less than 0.3 is imminent gangrene. So, pre-gangrene we call it. Answer is A. What about if it is more, like it is more 1.4, is it good? No, very high ankle brachial pressure reflex does not mean that the flow is good. It could be due to thick wall, poor wall compliance, calcified artery or erythematous artery, like diabetes. So, the wall has become stiff, compliance poor, so you can get high pressure without good flow. So, it should be less than 1.25 to be considered normal. More than 1.25 is considered abnormal, and if it is more than 1.4, it is definitely calcified erythematous artery, not good flow. So, answer is A. This is a very old repeated question asked many times. IOC of parathyroidnoma is system AB scan. If you have an option of system AB scan along with SPECT, then this is the best answer. Single positron emission computed tomography. This is the best. System AB plus SPECT. Otherwise, only, and when you do system AB, how you do? We give system AB and do the scan. You will find the uptake in thyroid, parathyroid, salivary gland, cardiac muscle, many places. Do the scan after 2 hours. Now, it will only be in parathyroid, all other side the system we get washed up. So, it is the late scan which is helpful after 2 hours, where you can see parathyroid. To see the anatomy, 4D CT is the best radiological test, but to see the location, system AB is quite good. Singeing of eyebrow, bilateral upper limb, anterior thorax burn percentage. This question is a tricky question, it's not very simple question, because they have not given how much percentage of burn is there on the face. Wallace's rule of 9 is quite simple, I am sure all of you know. Head neck 9%, upper thorax, anterior, posterior 9 and 9, abdomen 9 and 9, upper limb 9, lower limb, thigh and leg 9, so one limb 80, 1% perineum and genitalia. So, they are saying upper limb complete 9, bilateral 9, anterior thorax 9, 27. Now comes the face. They are not saying head and neck, so I cannot take complete 9. They are not even saying face. What they are saying? Singeing of eyebrow. Singeing of eyebrow is just grade 1. When I discuss Wallace's rule of 9, I clearly tell you 3 things. Number 1, it is for adult, not for children. Number 2, palm is 1%. Number 3, grade 1 burn is not included in the Wallace's rule of 9 calculation. So, grade 1 burn is not included means in Wallace's rule of 9, this is insignificant. If it is only a singeing of eyebrow, it is not included. Although some area of burn, grade 2, grade 3 burn, that will be included. So, it should be somewhere between 27 to 30%. Okay? 27 to 30%. Not a cause of recurrent renal stone. Citrate is inhibitor of crystallization. It is protective. Hypocytriuria is one of the cause of stone, not hypercytriuria. Normal citrate excretion should be more than 300 milligram per day, which is a MCQ. Hypercalciuria you get in hyperparathyroid, idiopathic or hyperabsorptive. Hyperoxaluria we get in all kind of malabsorption. In malabsorption, more oxalate is absorbed from GIT. This hyperoxaluria. Hyperuricosuriya also you can get in gout and chemotherapy, etc. Hypercitiuria is rather protective. Name the procedure. The same photo I showed in DVT in DAMS. This is SARDS. Single anastomosis duodenal ileal sleeve gastrectomy. And this is the slide I showed in DVT. Exact same photo. How to differentiate? Here I am doing sleeve gastrectomy and duodenal switch also I do sleeve gastrectomy. So how to differentiate between the two? In duodenal switch, this is duodenal switch. You make a Roux-en-Y and the common channel is hundreds. This is the common channel shown by green color here and here. In SARDS, we don't make a Roux-en-Y. We take the loop up and the common channel is 250 centimeters. You can see here. Common channel 250 and only one anastomosis done, while in duodenal switch 2 anastomosis done. So this was SARDS. 6-week-old child, non-bilious vomiting, non-projectile, abdominal examination normal. Now this question is tricky. They have really trapped you. Unfortunately, I think many of you must have answered CHPS, which is wrong, because number one, its age is more confusing. Number one, non-bilious, and number two, non-projectile, number three, no lump. In CHPS, the vomiting should, sorry, non-bilious is fine. Vomiting should be projectile, number one. Number two, olive-shaped lump, and maybe left to right peristalsis, which was also not mentioned. So without lump, non-projectile, I'll not make CHPS diagnosis. GE, small bowel obstruction, will have bilious vomiting. Milk allergy will have other features as well skin involvement, and it will be right after birth. GERD is the most probable diagnosis. This is the best diagnosis. Although GERD doesn't present with vomiting very often, it presents with belching, regurgitation and respiratory symptom. In neonate, respiratory symptom is very common after feed in like coughing and aspiration pneumonitis rather than vomiting. But out of these four, the best answer is GERD. This again I would say is not a good question for you, very idiotic question. They showed this image and asked what's being done here. This is the dog ear excision. See, whenever you have discrepancy between the edges, the length of the two edges of incision, then you may have some loose lax skin hanging at one end. We call it dog ear. Dog ear excision can be done where we only cut the one side, this one, and convert it into J or hockey shape. This is, sorry, this is how you repair the dog ear, or there are many other methods as well. So this was a dog ear excision. Only this flap you remove, leave the other side and convert into a hockey shape or just cover it. So this is a dog ear excision. Not a boundary of hepatocystic triangle, that is nowadays we call it Carlot's triangle. Bounded by liver, common hepatic duct and cystic duct. What is the content? Cystic artery. Cystic artery is a content of this triangle, not a boundary. This is the Carlot's triangle here, and this is the artery, which is a content, not a boundary. Cleft lip muscle repaired is You may have to repair all depending on how deep the cleft lip is, where it's located, central or peripheral. But one muscle which you need to operate always is orbicularis oris. This muscle has to be repaired because it forms the oral ring and the sphincter. So, like here, orbicularis oris needs to be repaired, this muscle, whether central or peripheral both. You have to repair the cupid bow, make it normal. You have to repair the philtrum and columella. All alignment needs to be done in but most important is orbicularis, this muscle, oris. This is the muscle you have to repair, orbicularis or to reconstruct the ring. Zygomaticus major, levator labii superioris and levator labii superioris alignasi, they may be repaired in lateral type, not in central type, but all orbicularis oris needs to be repaired. And in general, if I do not know the answer, still one knows that orbicularis oris forms a ring around the mouth, so this needs to be repaired. About Z-plasty, true statement is Z-plasty basically, this is the most common angle. You take 60 degree and you get 75% length increase. So, for contracture to reduce the tension and gain the length, we do Z-plasty, double transposition flap. Z-plasty is an example of transposition flap, double transposition, and it is to increase the length. Correct about VAC. VAC has become very favorite topic, vacuum assisted. You know, for bed sore, for burst abdomen, this is a January FMGE question, VAC is considered best treatment. I have taken 5 options because I am not sure which 4 were asked, and all are correct. This is another question in VAC, that what pressure you keep in VAC, vacuum assisted closure. Dressing, negative pressure minus 120, 125 is correct. Redressing after 4 to 7 days, correct. It promotes granulation, that's correct. It can be contrast-intermittent, that's correct, and reduces bacterial proliferation. By the environment of wound is very conducive for bacterial growth. Poor blood supply, slough, all this are removed by it. It promotes granulation, promotes blood supply, increases oxygen concentration. So, it reduces bacterial proliferation. So, D is the correct answer. VAC image may come in exam. In a wound, there will be a sponge. This is sponge in the wound. Then this is a vacuum suction and a airtight dressing. IOC of ureteric stone, very commonly asked question, has been asked many times. Answer is NCCT. Non-contrast CT is for ureteric stone as well as for head injury, like ectodermal dermatoma, NCCT, not CCT. And one more point, at the time of colic, never ever order IVP or CCT. If you order, because kidney stops functioning for few hours or maybe 1 or 2 days at the time of colic, so you will find non-functioning kidney. So never order neither IVP nor CCT at the time of ureteric colic, otherwise there will be no contrast on that side and you get the idea as if the kidney is not functioning, and it will become normal in a day or 2. So NCCT is the best investigation to see stone. A 40-year-old male presents to emergency department with head injury and severe respiratory distress with absent breath sound on the right side. देखो A, B, C, D and exposure. Airway, breathing, circulation. This you always follow the triage protocol of ATLS guideline. Airway, breathing, circulation, disability, exposure. So airway security is the first step, and this we have discussed many times. Whenever GCS is 8 or below, the first step should be intubation. ICD I will do after securing airway. Had it been tension pneumothorax, then one can put a needle in the 5th intercostal space first of all to relieve the tension, then intubate. But tension was like word is not used. So best is secure airway. That's the first step, airway. I'm not sure whether this question was there. Wording could maybe different, but probably a question like this was there. ARDS patient on mechanical ventilation, decreased breath sound on right side. And so this is a pneumothorax due to barotrauma, the rupture of alveoli, pneumothorax due to ventilation, one of the complications. Wrong match, although this is discussed in medicine and pathology everywhere, but I'll just tell you this because I also discussed this in STK11 is Peutz-Jeghers, P10 is Cowden, this is Lee-Frommani syndrome, and this is of course breast ovary syndrome. So Peutz-Jeghers can have breast cancer, can have lung cancer, can have testis and ovary cancer, sex cord, and pigmentation on the lip and GIT cancer. So breast cancer is found in Peutz-Jeghers. P10 thyroid, yes, P10 Cowden syndrome can have thyroid, breast, macrocephaly, endometrial cancer. And another important point, the thyroid cancer here is follicular. Usually you have papillary boson, but here follicular. Mucosal neuroma is not a feature of Lee-Frommani. This is a feature of men too. The gene is red. This is wrong. And BRCA 1, 2 for breast cancer, ovary cancer, peritoneal cancer. BRCA 2 for prostate, colon, pancreas also. 1 also can cause prostate. 2 also male breast cancer. So this can be there. Prostate, although not common with 2, but maybe this. But mucosal neuromas is not found in P53 mutation. This question was little unusual. This is X-ray deficogram, and unfortunately, this is normally we do in solitary rectal ulcer syndrome or rectal partial prolapse, which we don't discuss in MBBS. Like in regular batch, I don't discuss this topic. But fortunately, in rapid revision, live rapid revision, I showed you this topic in this slide, solitary rectal ulcer syndrome. This is the rectum, this is the puborectalis, the sling is tight, not relaxing. So during defecation, this part prolapses and develops the ulcer, the green dot. So presents with rectal bleed, ulcerated lesion on the anterior wall of rectum, painless bleeding caused by non-relaxation of puborectalis during defecation and internal interruption of mucosa causing an ulcer, and diagnosed by sigmoidoscopy, deficogram and biopsy. And I told you I have only seen one question till date in AIIMS almost 10 years ago. What is the histological finding of solitary rectal ulcer syndrome? And there is excessive collagen deposition in the lamina propria and abnormal proliferation of muscaris mucosae going into the crypt. This was the question I saw in AIIMS. This photo I showed you, same photo I showed you in rapid revision of LRR, the LLR, live rapid revision. So this is what this I showed you, and this image came in this exam. Well, cancer not related to obesity, this comes in pathology, medicine everywhere. All GIT adenocarcinoma associated with obesity, lower esophagus adenocarcinoma, stomach, pancreas, colon, liver, even thyroid, endometrial cancer, all. So this definitely, this and this. Even these two are related to obesity. Which 4 options were there, I am not sure, but probably if this is the option, this will be the answer. The least association is with multiple myeloma followed by meningioma. Both are related to obesity, but the risk is very low. So out of these 4, whatever option, this is the best answer. If this is not the option, like multiple myeloma is the best answer. If this is not there, meningioma is the option, then that is the best answer. White patch, this discussed in microbiology. This I showed the image, curd-like white patch in the mucosa, esophagus, and this is candida having pseudohyphae, and this is HPV-16 causing squamous cell cancer. This also we discuss in esophagus. And this is discussed in radiology again. No hostra, dilated colon, lead pipe appearance, distended bowel. This is ulcerative colitis. So, these questions I am not framing the question and telling you options, because these are discussed in other topics. One question is left, that was Muir and Barclay formula. See, in burn fluid calculation, we tell you only one Parkland formula and ATLS guideline. But in burn, I also tell you Muir and Barclay formula. 0.5 ml per kg per percent. This is 1 unit, and this you give 4 hour, 4 hour, 4 hour, 6 hour, 6 hour, and then 12. This is total 36 hours. If the person weight is 80 kg and he has sustained 30% burn, let's calculate 8 is a 24, 24.5, 1200 ml. So 1200 ml I'll give in 4 hour, then 4 hour, then 4 hour, and then next hour, and finally. This was not the question. Question was what fluid we give. The fluid of choice for burn is Ringer lactate, but three formula we use colloid. Muir and Barclay, Brooks and Evans. These are three formula where we use colloid. In Brooks, the ratio is 25, 30, 75. So, in Brooks, we prefer plasma, while in Muir and Barclay, we prefer albumin, human albumin solution. Not dextran, not plasma, that was option. So, one question was what fluid is used for Muir and Barclay formula. For Muir and Barclay, we use albumin. And how you calculate the fluid? I told you the formula also. You may get a question on this, you never know. NEET may be पूछ सकते हैं, but this is a rare question. More often they ask Parkland and ATLS formula. Okay, so that's it. These were the questions asked in INICET this Sunday. Sorry, 2 days back. Okay, so all the best to all of you. Thank you.